wanted to start off with a question actually for all of you because it came up in all of your talks, but I'm going to actually point it to Dr. Moayeddi first because it's primary prevention. So we need an HP eradication trial in the US, right, among asymptomatic individuals. So what does that look like and how do we power that so we can actually do such a trial?
What I would highlight is that I'm not sure you need a US trial. Sorry. But there is a UK trial going on. It probably will be underpowered. I don't know. But it probably won't give a definitive answer. And if it doesn't, then yes, you may well need a US trial. I would emphasize that we're people. So if you don't have nothing in the US, but everywhere else in the world they're showing this, it's going to work in the US too. So I emphasize this because H. pylori was discovered in Australia. Europe took it on very quickly and cured ulcer disease. America didn't until it was proven in America. And of course, it's exactly the same as Europe, because at that time anyway, it was a very much European type population. So I think, there may be more evidence, but if there isn't enough, then it's important to do it in a well-resourced country like the US. I would follow Nick Wold's thing, which is a really elegant trial. He took private patients who'd had blood tests for screening, and he randomized people to have the test for H. pylori, and if positive, treated. But the other ones he kept and will test for H. pylori as well. So at the end of 10 years, 15 years, you'll have a group of people who you know are H. pylori positive and have had treatment, and a group of people who you don't know what they are yet, but then when you test them, you'll see who's H. pylori and they didn't get treatment and what was their cancer risk. And I think that's a pragmatic way to doing a study in people who've already had blood tests in the US, and believe me, that's a lot of people. So you could do a very large trial relatively quickly with that sort of design.
Great.
That's a great comment. I actually want to, just like mention a limitation now in the U.S. Now, many places already stopped the serology testing. So in Kaiser, we don't really have any more serology testing. We only rely upon the non-serology testing. So I think because of limitation of serology, I guess we can just start with testing high-risk groups, because that's probably the most cost-effective way to screen for H. pylori. For example, among East Asians or East Europeans, so we have to design start with small trials and see what happens in terms of feasibility.
Sorry, I disagree, because yes, you may not do serology, but on the serum that you have, you're perfectly capable of doing serology on it. Just because it's not part of your clinical algorithm doesn't mean you can't do it as part of research. And I think, as you can see from the gastric cancer data, even higher risk than any US population, which is Korea and parts of China, you need 50,000 people. Yeah. So you do it in a couple of thousand. Yes, it's a small start, but you won't see definitive answers, and I think that's what you need. So working towards it, I think we're past that. We need to definitively say, this is what we should do in the States, or this isn't.
Thank you. I know we have a lot of questions. Joo Ha, do you want to weigh in on this, or we should move to questions?
Oh, no, let's move on.
Okay. Dr. Parsonay.
Yeah, I actually had a number of questions. First of all, 30 years ago, we looked at the number we needed for a randomized trial, and it was prohibitive in the United States to do that trial. I totally agree with Paul that we would have been underpowered. It's too hard. I have actually, and I wanted to make one other comment, which is I am such a huge fan of the Kaiser Division of Research and the work that you guys do and the possibilities you have in that cohort. So just hope that you can keep pushing on it, because it's such a great research database. So I had two questions. One is about H. pylori eradication. Nobody's really mentioned how hard it is to eradicate H. pylori in very many people. And there was, in the past, there's been some thought that people in whom you can't eradicate H. pylori, those people actually have less inflammatory states and that they may actually be less likely to get gastric cancer down the line. So I'm wondering if in those randomized trials, anybody's ever looked at the people who failed H. pylori eradication and compared them to the people who are in the placebo group to see what happens. So that's question number one. And question number two relates to other things that we did in the past, which is we looked at other markers. So we looked at pepsinogen and gastrin and all these other things, which we don't do anymore. And it gets back to that AI question. There are now all sorts of liquid biopsies and proteomic studies, and I'm wondering how these are being combined with other screening possibilities and whether those are proving to be useful in any way in identifying who needs further screening.
Yeah, so I guess in the trial question, it's a very good one. As far as I'm aware, no one in randomized trials has looked at those who failed treatment versus success. But we have looked at this in cohort studies, and we haven't published that. But what I would say is that concept cannot be dramatically true. Sorry for the poor wording. But basically, those who have successful eradication have a lower cancer incidence than those that have failed eradication. Now, whether they have, they're truly at the same risk as had they not had eradication, I don't know. But I don't think that I use it to reassure my patients when I can't possibly treat them anymore, but I don't believe the data support that. So I think that's the question I can answer. You've got more questions around liquid biopsies. Maybe the panel want to.
I don't think there's data in the U.S. Regarding the new biomarkers or liquid biopsy that can be really useful in clinical practice yet. But I think Robert and Joo Ha, you did a study on pepsinogen, which is kind of intriguing because in East Asia, it was sort of very effective way to screen for high-risk patients, but in the U.S., was not really as effective as it was in Asia.
Yeah, and there's a couple reasons for that. I think the U.S. population is much more heterogeneous, whereas the Asian populations are much more homogeneous. And there's this hypothesis that there's differences in kind of cellular mass, because what the pepsinogen does is it tests for atrophic gastritis, looking at a ratio of pepsinogen 1 to pepsinogen 2. We had a dinner last night where Paul actually, I think, came up with a better explanation. You want to delve into that one?
Yeah, epidemiology, which Julie turned me on to, is a great thing because it's maths, and maths doesn't tend to lie. It tells you what you're going to find. And basically, the pepsinogen ratio has roughly a likelihood ratio of 2, which sounds great, double the chance of having something really serious. But in low-risk populations, that means the vast majority of them that you think are positive are actually just at no risk. So the liquid biopsies in general, I think I would predict in the white population are not going to work in gastric cancer because the background prevalence of cancer is just so low. Even if you're 99% sensitive and specific, which they're not, that's still not good enough. So I think the liquid biopsy may have relevance in the high-risk populations that have been talked about, but I don't think they're useful in the general population.
Yeah, I think it goes to testing the right population, because if you just test everybody and it's a low-risk population, your likelihood of getting a false positive is much more likely than it actually being a true positive. And so I think that's why some of these tests don't work right now.
I just want to follow up. I don't want to make it sound like I'm interested in pepsinogens because we studied pepsinogens and I'm not interested in them at all. So,
No problem.
Thank you.
Scott?
Yeah, please.
Thanks. Just a comment and a question. I think the comment is we need a T-shirt that says, please disaggregate your Asian data. I think that is so right on. The question I have is for the clinicians, if you have a 50-year-old East Asian, first generation East Asian immigrant coming to you for screening colonoscopy, asymptomatic, otherwise healthy, no family history of GI cancers, what's your approach?
I recommend upper endoscopy, one-time upper endoscopy, absolutely. And then I'll risk stratify based on that.
What about H. pylori testing?
I will test for H. pylori at the time of endoscopy, so I'll do biopsies, and that will cover the H. pylori as well. I think that's the most pragmatic way to do it. The practical part of this is insurance companies will 100% cover the colonoscopy because the USPSTF has guideline recommendations on that, and then the patient will be responsible for the upper endoscopy. And so depending on the type of insurance that they have, they'll always have a copay. And the problem with like immigrant populations often have small businesses and they have high deductible insurances. So what really got me started in this was I was taking care of a good friend of mine in Seattle, and it was this exact same situation. I said, you need an upper endoscopy. After the upper endoscopy, and I was at a county hospital, and we charged Medicare $200 for an EGD, so I didn't think it'd be that expensive. He got charged $5,000 for that endoscopy, you know, and I said, this is wrong. Right? It's like we're doing a screening examination, and he had findings too. And so, you know, I had to fight my hospital saying, how much do we charge Medicare? $200. How much are we charging this patient? Initially, they wanted to charge him $5,000. They said, we're going to drop that, right? And so we negotiated that. But that's the inequity. That's the practical inequity in our system.
I totally concur with what Joo Ha said. That in concept, although in practice, we have not done this yet in the U.S., and we should start somewhere. And at Kaiser, for example, we have a prepaid system. Still, we have cost share issue because there's some people have like high copay, others have low copay. So you add endoscopy, they may have to pay out of pocket like $1,000, $2,000. That's a potential barrier deterrent for them to get endoscopy done.
Yeah, I actually tell them go to Korea business class, and a nice hotel room, and it'll still cost them less than what they're gonna get charged, and they'll probably get a better exam.
They could just go to K-Town in LA.
That's true.
Or they could come to Canada.
But I think this
So
is
you wear
real-
a T-shirt saying healthcare should be a centralized taxpayer system because it is a right, not a privilege to have healthcare. And what we do in Canada is we actually test for H. pylori first. So we don't want to waste taxpayers' money. If they're H. pylori negative, yes, they could, but it's much more likely in a 50-year-old. So we would not do the endoscopy. But if they're positive, we want to know what the state of their stomach is, and we would do a screening endoscopy in a 50-year-old who is having screening colonoscopy as
I'd
well.
say the problem with that approach actually is it misses the highest risk group.
Yeah.
Right? It's the patients who have burnt out atrophic gastritis who no longer test positive for H. pylori. Those are the patients who are at the highest risk. So that's why I don't feel that a single H. pylori test, especially in an older individual, I think maybe in a younger individual who's in their 20s or 30s, that's fine. Test and treat and you're done. But in an older individual, you could have the scenario where they have burnt out atrophic gastritis, they're negative. Those patients are at extremely high risk of going on to gastric cancer. So that's why I still think an index endoscopy is necessary for risk stratification.
Thank you. Or the ABCD method, right? And do pepsinogens if people don't like. But anyways, it's time. We're late for lunch, so thank you all so much.
Oh, yeah,
I'm sorry.
we'll take one last question.
Oh,
yeah,
okay.
that's okay.
Okay,
I run this thing, so
You do?
we can, they'll hold lunch.
Thanks, Dr. Huang and Hee Woo from City of Hope. Thank you for your wonderful presentations, and I'm learning a lot. I have one comment, and then I'll have a question for Dr. Lee. One comment is that if you look at the California Cancer Registry, 40% of Korean Americans are being diagnosed with early gastric cancer. And this may have to do with the fact that some of this practically is already occurring within the Korean American population, especially in like New Jersey, LA, K-Town. And so I think some of this in real life is occurring. The question that I have for Dr. Lee is, in all the patients that are being tested for H. pylori in your cohorts, do you see a higher rate of endoscopy being performed? And if so, are there earlier cancers? At City of Hope, we see 75% to 80% advanced, and almost 50% of them by referral patterns are stage 4. So I see about 10% early cancers. And so I'm just wondering if you're doing in your cohort of population of clients, if they all, they're getting H. pylori testing in that cohort, are they getting more endoscopies, and are there higher early gastric cancer rates?
We don't have data to answer the question because we just know the test positive rates in our member population, but we don't really know whether those test positive got higher chance of getting endoscopy. That's the we can look into it.
Did they
Yeah.
get an endoscopy? Can you test that?
Yeah, we can look into, but we don't really have answer to that question because we didn't really look into among those got tested positive, who a portion of endoscopy happening to those patients. So, but that definitely is a very important question we can look into.
Okay, one last question.
It's more a comment.
It's his fault for not getting us to
No, I
lunch.
think actually Ernst was before me, but I have to comment on these two things I just heard, and I don't think they fit. You said you stopped serology at Kaiser's. At the same time, I hear that atrophic gastritis is those patients we overlook when we test for H. pylori. And I think this is exactly why we still need serology. And there's tools around now where the serology allows you to predict if someone is still positive or has only a history of H. pylori with 90% accuracy. So I just want to put that into a different perspective. I think serology is the most potent and cost-efficient screening measure we have in our hands.
You know, I thank you for that comment. I actually disagree with our decision, as in many places in the U.S., to discontinue serology altogether because there's some occasions you still need serology. In patients with ER with active GI bleed on PPI, you take biopsies, you're not going to show H. pylori. So I think on some occasion you do need serology, and also is a really quick way to test H. pylori. I think I don't disagree with you. I think just like it's just what happened. So, but we don't have ability to test H. pylori by serology.
Yeah, what I was saying when I said test for H. pylori, in Canada that's serology, and that's what we would do, yeah. I don't know if Ernst, was the only question, why can't we let him?
Yes, Ernst, you so patient.
No, thank you. So just as a tease to Paul, I wouldn't go to Canada for an endoscopy because you have to wait for 2 years.
I was going to say that too.
You better come to the Netherlands for that. But my question was, so we first focus on the Sydney protocol for biopsies. I think it's important to realize that this was written down 30 years ago by pathologists at a time when we had our first generation video endoscopes, which were relatively, compared to what we knew now, have very, very poor. Next to that, when we wrote down the old gym protocol and came with a suggestion, it was never just simply only intended to be based on biopsies. And I think it's important to stress that. So if we combine the two and we really want to make the major steps, as has been suggested, and I'm very glad with that, we might want to consider, once we've achieved the level of appropriate training of our endoscopist, we might actually achieve two targets in one. For one, just do the endoscopical evaluation. You already know your old gym stage, and then you can take targeted biopsies when you need that.
Yeah, completely agree with you. I think that that's rational, and I hope we're going towards that. I agree.
I agree. The only comment I would make is you've watched too much Fox News. My waiting list for average risk colonoscopy is about 5 weeks. So
I attended a meeting for the Canadian Association of Gastroenterology together with Paul many years ago, and we came up with a protocol for this, which we call TWEEDY, test and treat while waiting for eventual endoscopy in 2 years.
Thanks to all the speakers.